right, so we're going to do today some midterm review. So we're just kind of go rapid fire through the topics we've covered so far. Just kind of starting with valvular pathology. So again, just always, as you're breaking down these questions, always remember, what the heart's response is to pressure overload, what the heart's response is to volume overloads. Just remember that regurgitation or insufficiency, that's considered a volume overload. Stenosis is, when we're talking about the valves, that's considered a pressure overload. And then understanding the heart's response for each of those. So when it's a pressure overload, with the semilunar valves, you're going to wind up with ventricular hypertrophy followed by dilatation. If it's a volume overload with regurgitation on the semilunar valves, the heart's response is going to be enlargement, so dilatation of that chamber, it's going to enlarge, and then followed by hypertrophy. When we're talking about the atria, whether it's pressure or volume, we just have dilatation of the atria, so we have enlargement of the atria. That's when we have disease on the AV valves. So first thing we're going to discuss, we're just going to kind of put on our charts, because these are numbers that, eventually you're just going to have to commit to memory. So first, we're going to just make our mitral stenosis chart, so MS. So we can have a mitral valve area. So in terms of grading our severity of mitral stenosis. So normal, I'm just going to put an N, normal, mild, normal mitral valve area. This is going to be 4 to 6 centimeters squared. When we're talking about mild aortic stenosis, does anyone remember what the valve area would be for mild aortic, mitral, mild mitral stenosis?
Isn't it greater than 1.5?
Yep. Yeah, greater than 1.5. What about moderate, anyone?
1 to 1.5.
1 to 1.5, good. And severe?
Less than 1.
Less than 1, good. So we're going to do that way, less than 1 centimeter squared. So those numbers you should commit to your memory. So mild is going to be greater than 1.5 centimeters squared. Moderate was a valve area of 1 to 1.5 centimeters squared, and severely stenotic would be a valve area that's less than 1 centimeter squared. So there's a couple different ways that we can, calculate the severity or degree of mitral stenosis. The first one, is going to be planimetry. Can never pronounce it right. So that's where we're actually physically tracing the valve orifice, the opening. So that's done in our parasternal short axis view at the level of the mitral valve. So it's that fish mouth. So we trace the valve when it's open during diastole to get the valve area. So that one, again, takes some good technique. You really have to zoom in, get a nice close view, a nice clear view. And that could be, fairly challenging, depending on the patient. So if you're unable to, trace the actual valve opening, the orifice of the valve, you could use pressure half time. So that's probably the most common method of determining mitral valve stenosis. So we can add that to our chart, our pressure half time values. P half time, pressure half time. So our normal pressure half time, this is going to be 30 to 60 milliseconds. For moderate stenosis, you have 90 to 150. Moderate is 150 to 219. And then severe is a pressure half time that's going to be greater than 220. Oh, sorry. And that's milliseconds. So just remember that our equation for mitral stenosis to calculate the valve area, so it's mitral valve area equals 220 divided by that pressure half time. So if you take that equation, if you kind of look at it, if you have a pressure half time that's greater than 220, so if I put a number greater than 220 into that equation as my denominator, that's going to spit out a value that's going to be less than 1. So that's how, that equation works. The other measure that we can use is going to be our mean pressure gradient. So just remembering your values for mean pressure gradient now. So under moderate stenosis, I'm just gonna kind of separate my chart here a little bit. Moderate mitral stenosis will have a mean pressure gradient that's going to be greater than 5. I'm sorry, less than 5. I apologize, less than 5. Moderate is going to be 5 to 10. And for severe mitral stenosis, this is going to be greater than 10. This is millimeters of mercury. This is a little chart that you should have, with you at all times when you're in the lab. It should be in your little notebook, your handy dandy notebook of numbers. And these are the numbers that, you're going to need to really ingrain in your head, particularly the two extremes. So if you know severe and you know mild, you can kind of figure out, what falls into that moderate, if they ask you questions when it comes to your boards and your registries. If you know mild and you know severe, you can figure out, all right, that number is not mild, it's not severe, so it's got to fall somewhere in the middle. If you can't remember these exactly what the moderate values are. In terms of calculating these things, so again, when we're measuring our pressure half time, well, before we even measure pressure half time, one of the first things we can, get an idea if this patient actually does have mitral stenosis is just kind of looking at that valve itself, doing our visual assessment of the valve. Do the valve leaflets look thickened? When we do our M mode, the M mode is not going to take on a classic appearance. So when we do our M modes, instead of getting our nice cat ears, so if we do our M mode, normally we'd have something like that on our M mode. So this would be normal. We're going to get something that's much flatter. So we'll have reduced motion of that leaflet. The leaflets will also appear thickened as well. So M mode, when we're going through our study, when our parasternal long axis view, we do our M modes, we'll be able to pick up, all this patient, most likely, is going to have a stenotic mitral valve that we're going to have to interrogate and start calculating numbers just based on how that M mode is, how that valve is opening. So if you start losing your nice pretty catheters and you get something that looks flat, your E to F point, becomes flattened. So it may not be as severe as that, that'd be an indication, someone that has severe mitral stenosis. But if you see some degree of change from what looks like your normal M mode for mitral valve, you probably have to start doing your calculations once you get into your apical views. So this is actually going to all really come together and make a lot more sense once we start doing apical in our lab and we're actually calculating these values and measuring these values. So how do we actually get to these values, the mean pressure gradient and pressure half time? We're going to measure our mitral inflow. So we're going to measure mitral valve inflow and apical fortune view. So with our mitral inflow, normally we'd have our nice E and our A waves, but when we have mitral stenosis, we get a flattening of that E to F slope. We may actually lose the A wave depending on the severity, of that mitral stenosis, or that A wave might be kind of lost in that initial opening. But we're going to measure for pressure half time. We're going to go to peak E. So that's going to be our E wave. And we're going to measure along that E to F slope. So you're going to take your caliper, measuring pressure half time. You're going to measure along that slope. So just remember with pressure half time, you don't necessarily have to go all the way down to this baseline. So basically what it's measuring is it's calculating the time it takes for this pressure, the slope of this line to decrease by half. So the steeper this is, the faster it's going to drop. So the quicker the time is going to be for that pressure half time. So the pressure half time is going to be less. It's going to be smaller the steeper this line is. The flatter this line is, the longer your pressure half time is going to be. So if you're measuring along the slope of that line, the time is going to be longer for it to drop by half. So the flatter the slope, the longer the pressure half time is going to be. So that's going to indicate more severe mitral stenosis. So you're going to get a larger pressure half time. You plug it into your equation, you're going to get a smaller valve area. Does that make sense to everyone for pressure half time? Yes, yes, yes. The other option for mean pressure gradient, you're tracing velocity time integral. So you're tracing along that entire curve. So anytime you see mean pressure gradient, to calculate mean pressure gradient, you're going to have to trace along that entire spectral envelope. So for mean pressure gradient, you have to trace, your VTI, so your velocity time integral. Start at the baseline at the start of your wave. Trace along, trace along, trace along. trace along, trace along, trace along, trace along. Make sure you include the entire envelope all the way down to your baseline again. So tracing along the entire spectral tracing. And that's basically averaging in all the velocities that are underneath that curve to calculate your mean pressure gradient. So basically what mean pressure gradient is, it's telling you what the I guess the difference in pressure, or that gradient between the left atria and the left ventricle. So if you have a large gradient, a large difference in pressure between the left atria and the left ventricle, that can be kind of determined to, evaluate the severity or degree of stenosis. So if I have a highly stenotic valve, pressures are going to build up in that left atria. So I'm going to have a large pressure gradient of when that valve opens up and blood flow is trying to get across to the left ventricle. So I have really high pressures due to that really stenotic valve in my left atria. The pressures are low in that left ventricle. So that's why, as the stenosis gets worse, that pressure gradient starts increasing and increasing. So it's harder to get that blood flow, through that valve. Pressures are going to start going up because it's very stenotic in the left atria. So that's how mean pressure gradient works. This is kind of how you need to kind of think about it in your head. There is one more method that can be used. It's deceleration time. Mitral valve. Deceleration time. So this is the deceleration from your E to F. So with deceleration time, you're still measuring along that curve, but now you have to take that line all the way down to that baseline. So I'll measure from peak E baseline. So I'm just gonna put 0. So you're measuring all the way down to your baseline to 0. So in our textbook, they actually had one that was kind of exaggerated just so you could appreciate it. So it was kind of more like, it's like a little A wave. So in that case, when they measured along that slope, it continued all the way out, actually even past the wave. And that's when you would stop measuring for deceleration time. And then the formula for this to calculate your mitral valve area with deceleration time was MVA equals 750 56, 59, 56, 59, 59, 19. Divided by deceleration time. All right. Let's erase this. All right, so Rachel, if I got a patient with severe mitral stenosis, and I put the probe down on his chest, what's one thing that I might see? What's something that I could potentially see if this guy's got severe mitral stenosis? Putting you on the spot.
Like narrowing of the valve.
Sure. So we got thickened. Yeah, we got thickened leaflets, narrowing of that mitral valve orifice. So you can see that on the envelope. So thickened. Narrowing of effective orifice area. Abbreviate that EOF. What else can we see? We're going to make our lists, because this is kind of how your registry boards are going to go. They're going to give you, patient has, this certain condition, you could potentially see all of this, this, and this, and this. And then one of the things, you're not going to see. It's not going to make sense. And you're going to have to pick the one thing that doesn't make sense that you can potentially not see or not go. Something that could not happen. What about Mary? What else do you think we might see? This patient has severe mitral stenosis. We put that probe down. What else could we potentially see?
They could have a parachute mitral valve.
Sure. Yeah, I mean, that could be a cause of mitral stenosis. They could potentially have a parachute mitral valve. That would be an example of something congenital that could cause mitral stenosis. Let's say this is due to just say it's due to rheumatic fever or something like that, or say it's just severely calcified. So we know this guy's had severe mitral stenosis for a while. What else is going to happen to that heart? What else could we potentially see? Marissa?
Left atrial enlargement.
Good. And that's the first thing. That's the big one. Yes. So you can see LAE, left atrial enlargement. So 100%. That's going to be probably the first thing that's going to happen to this patient. That's the first chamber that's going to be affected. So we have a stenotic mitral valve. It's severely stenotic. This guy's had it for a while. So yes, probably 110%. That patient's going to have left atrial enlargement. So if he's got left atrial enlargement, what other things could potentially be wrong? What else could we potentially see? Want to give me something, Juliana?
Is it the hockey stick?
Sure, if it's rheumatic, yep. The patient would have a mitral valve, hockey stick. MV. So I'm just gonna put over here rheumatic. disease. So that's rheumatic heart disease affecting that mitral valve.
They could have like congestion in the lungs,
Absolutely,
fluid.
yeah.
build up.
So, yeah, exactly. Everything's gonna back up. So after you're done damaging your left atria and making it all big and enlarged, elevated left atrial pressures, that pressure is gonna back up to the lungs. So yeah, so pulmonary congestion. And I'm just gonna put slash pulmonary hypertension, HTN. So left atrial enlargement. We can also put, I'm gonna put a little arrow up here pointing up. So increased left atrial pressures. What else? Let's put our echo hats. What else can we potentially see?
Would their E to F slope decrease?
I'm sorry?
Would the E to F slope decrease on MV?
Yeah, definitely. Yeah, so that E to F slope will have a flat E to F slope. Yep. So there's- E to F slope. Upward. There's a whole multitude of things. So realizing like the whole list of things like we could potentially be seeing with this just severe mitral stenosis is going to help you to answer a lot of these questions on your boards. Keep thinking, what else? We still got a bunch of things to go. So this patient.
Is there like, does that cause like the D-shaped ventricle eventually too?
Yes, yeah. So if they have pulmonary hypertension now, if it's backed up to the lungs, they have elevated pulmonary pressures, yeah. That's gonna get translated over to the right side of the heart, so we'll have a flattened D-shaped septum. So that's when we have our parasternal short axis view. We're at the level of those papillary muscles, and we see the septum looks very flat. So instead of a nice round ventricle, the septum becomes flattened. We'll try it over here. I'm kind of just exaggerating a little bit. So if we're in our short axis view, our septum now becomes flattened. So instead of being nice and round, coming around like that, we get a flattening of that D-shaped septum that we see during systole and diastole. Anything else you guys can think of?
If it backs up to the right side of the heart, you can have right ventricular dilatation.
Yep. Yes, so before dilatation, so remember this is stenosis. So this is a pressure overload. So what's the ventricle going to do?
Hypertrophy.
Hypertrophy first. So yeah, so we can wind up with RVH. And then that's going to be followed by right ventricular enlargement. So you can get both, particularly if this has been long standing. But first, Right side's gonna hypertrophy now too. So this patient has severe mitral stenosis. Something else I'm worried about now, or something else that's gonna potentially cause. Big one is gonna be AFib. So these patients with severe mitral stenosis, that chamber is becoming large, it's become dilated, it's not gonna function properly. So they're gonna go into some sort of arrhythmia. And the most common being AFib. These patients, you know, they'll probably have AFib. So if they have AFib, there's not gonna be an A wave that we see on our inflow patterns. Some other things, you know, that can potentially happen. I'm gonna put 10 here. I would also be worried now about LA thrombus. So blood flow is having a hard time getting into the ventricles. It's going to start becoming more stagnant, that flow, because it's having a hard time getting into that ventricle. And particularly as that chamber starts dilating more and more, you're making a nice prime environment for the development of thrombus, particularly in that left atrial appendage. So we have to worry about, you know, patients developing left atrial thrombus. That's why often patients who have longstanding AFib, they're on some sort of anticoagulation treatment. So if you want to just keep going further downstream, so we got right ventricle hypertrophy and then becoming enlarged. That extra pressure now in the right ventricle can also get translated to the right atria. So you can wind up also with right atrial dilatation. Eventually that can spill back into the IVC and hepatic veins. You can wind up with dilated IVC, dilated hepatic veins. So like you see, everything can kind of just back up from that mitral valve. So pulmonary hypertension, remember that we also said that was our absent A wave on our pulmonic valve M mode. That's one indication of someone with pulmonary hypertension. I'm sorry, not absent A. Yeah, so absent A wave. So that it's also called the flying W. So there's an absent A wave on the pulmonic valve M mode. And it's also called the flying W. Pulmonary hypertension. I'm just going to kind of put it over here. M mode of PUV, pulmonic valve, has absent A wave. And this is referred to as, say, AKA, also known as flying W. That's a pretty good list. Again, most common cause of mitral stenosis is still going to be rheumatic heart disease. All right, MR. So the biggest takeaways for MR now, to really, determine whether it's mild, moderate, or severe. With MR, we typically give ranges. It'd be mild or trace. And then when I was working, we just kind of do like mild to moderate, moderate, moderate to severe, severe. So we kind of just give ranges based on how far back, that regurgitant jet goes within that left atrial chamber. So this is typically best seen, on your either 4-chamber, apical 4 or apical 2 chamber. So for MR, I know the boards will really like you to be able to know when you're talking about severe MR. What some of the characteristics are. So with severe MR, that regurgitant jet is going to go all the way back to the back wall of the left atria. So the regurgitant jet is going to be directed all the way to that back wall. Sometimes that can be a little bit difficult, to ascertain, particularly if it's an eccentric jet that's going along, the walls. So it may hit the actual walls of the chamber, and even though it's hitting those walls, it may not reach all the way back to that back wall. So you just have to be careful when you're talking about eccentric jets. But one of the things that we're going to look for with severe MR is if there's regurgitation or reversal of flow in the pulmonary veins. So with severe MR, we're going to see systolic flow reversal, pulmonary veins. So when we Doppler pulmonary veins, normally we have our pulmonary vein waveforms. Our S systole, diastole, and then our atrial contraction. Normally our S wave is going to be equal, or it's usually a little bit bigger than our diastole in terms of pulmonary vein flow. We get more flow into that left atria during systole than we do diastole. So this is our normal condition. In patients that have mitral regurge, if it's mild to moderate, we're going to get a reduction of that pulmonary venous flow during systole. So our S wave becomes smaller and our D wave becomes larger. So we got a kind of a reversal. So that'd be someone that had, mild to moderate mitral regurge. But when there's severe regurge, we actually wind up with, like I said, flow reversal. So below the baseline during systole, and then the majority of our pulmonary venous flow entering the left atria during diastole. So that's something, that the boards are going to want you to recognize, that with severe mitral regurge, you get systolic flow reversal in the pulmonary veins. So during that systole component, we are seeing flow below that baseline. So be able to recognize, your pulmonary vein tracing and what's going on. So if you know what a normal pulmonary vein tracing is supposed to look like, you can recognize, something's abnormal here. All right, what's going on? All right, I see reversal of flow during systole. So that means that this patient could potentially have severe mitral regurge. So when we're talking about things that can happen or things we could see with mitral regurg, so it's a lot of the same effects that it's going to have on the heart as mitral stenosis. So we said, and again, atrial's response to either pressure or volume overload is going to be enlargement or dilatation. So we're going to have our left atrial enlargement, left atrial dilatation, and all of them the things that come along associated with that. So again, we have increased left atrial pressures. Patients can wind up with AFib. They run the risk of developing left atrial thrombus. So we could see what's called smoke or spontaneous echo contrast. So that's that swirling of the static blood or blood that becomes more stasis or slows down. So we're actually able to, almost we see the reflections of those red blood cells as they slow down. So it creates a smoky appearance within the ventricles. So that blood flow looks smoky. And that's actually reflections of the red blood cells as they've been slowed down. So again, so if, left atrial pressures are elevated, all that's going to, again, get translated back to the lungs. So just kind of work your way in reverse. Pulmonary, congestion, pulmonary hypertension affects the right side of the heart. But now, since that this is a volume overload, an issue with volume, the right side of the heart, we're going to have right ventricular enlargement first, and then followed by right ventricular hypertrophy, and then right atrial enlargement, and then backing up, dilated IVC, dilated hepatic veins. Let's see what else. All right. We'll talk quickly too for mitral regurg. So some things that could potentially cause mitral regurg. It's important to know, what some of these causes could be. Can anyone think of one? What are some conditions that could potentially cause mitral regurg?
Rheumatic heart disease.
Sure, yeah. So oftentimes mitral stenosis is associated with mitral regurg. So patients who have rheumatic heart disease.
Like in a MI, if it displaces the papillary muscles.
Very good, yeah. Post MI. Yeah, so anyone who's had any sort of heart attack, any sort of myocardial ischemia, the left ventricle is going to remodel, it's going to reshape, it's going to rework itself. So if wall segments aren't contracting properly, those chordae that are connected to the valve leaflets aren't going to function properly. They're not going to collapse. So if one side of the wall isn't coming in, that's going to prevent that valve closure from closing properly. So if the heart, again, so if we have dysfunction of the motion of the left ventricle, that's going to in turn affect the papillary muscles in the chordae and potentially cause MR. So particularly if we have a condition, where we have a papillary muscle rupture, that would cause immediate acute, severe mitral regurg. So that would be a patient that all of a sudden has sudden onset of symptoms. All of a sudden, they can't breathe, they're short of breath because they have all this blood flow that's just now rushing back because one of the papillary muscles actually ruptured. So those patients are going to have, severe onset of symptoms. Oh yeah, so post MI. So it could be due to, wall motion, small segment motion abnormality, or it can even be due to ischemia to the papillary muscle itself. So I'm going to put under here too, another important thing to remember is that the posterior medial papillary muscle, so PMPM, is most likely papillary muscle PM to rupture. This is due to a single coronary artery blood supply. So the anterolateral papillary muscle is actually supplied by 2 coronary arteries, whereas the posterior medial is just supplied by the one. So the posterior medial is just supplied by the right coronary artery, whereas the anterolateral is supplied by LAD and branch of the left circumflex and the LAD. So that might potentially show up on your boards asking you which papillary muscle is the most likely to rupture. How did I there? I guess I'm just I'm laughing to myself because the way I remembered it was like I'm a mother effing PIMP. I don't know why that looks like pimp to me, but like you're screwed if that one ruptures, you're in trouble. Like,
I'm not gonna forget
don't
that
mess
now.
don't mess with the pimp. It looks like pimp to me, PIMP. But posterior medial papillary muscle is most likely to rupture. These are little facts you got to remember. Don't be singing it to yourself when you go into your boards. All right, so other causes of mitral regurg. So we got some rheumatic heart disease, post-MI. So that could either be due, yes, to wall motion abnormalities or actually ischemia to the papillary muscles themselves. Papillary muscle rupture. So, rupture. Other things that could cause MR.
MVP.
Yes, absolutely. Mitral valve prolapse. Very good. Good. That takes us down another rabbit hole. What's the best view to assess for mitral valve prolapse?
Parasternal long.
Yes, parasternal long. Parasternal long axis. What are some diseases, particularly congenital diseases, that make someone more susceptible to developing mitral valve prolapse? Like, what are some congenital diseases that we have to associate with mitral valve prolapse?
Is it aortic coarctation? Or is that something else?
Yes, coarctation is one of them. Yeah, so there is actually correlation with coarctation. Yeah, so if the patient does have a coarctation, I am gonna definitely assess mitral valve, so coarctation of aorta. I think some of those connective tissue diseases. There's the big one. Abraham Lincoln. You guys know Abraham Lincoln had Marfan syndrome?
I did not know that.
Did I know that? Yeah, that's fine. He was a huge, tall, lanky dude, man. And then he wore the big hat to even make him taller. But yeah, he had Marfan syndrome. At least it's believed he had Marfan syndrome, from what I've read. But yeah. So yeah, so Marfan syndrome, that's the big one. So you have to associate Marfan's syndrome with mitral valve prolapse. They go hand in hand. So Marfan syndrome also has to do with aortic dissection or dilatation of that aortic root. So any of these connective tissue disorders are going to be associated with mitral valve prolapse. So Marfan syndrome, then Ehlers-Danlos. Another one.
Could cardiomyopathy be one?
Absolutely. I was waiting for someone to throw that one out there. Which one? Which cardiomyopathy?
Dilated.
Yeah, I was gonna say dilated.
Yes. Dilated cardiomyopathy. Very good. Yes. So as that chamber becomes more and more dilated, you get stretching of that annulus or separation of that mitral annulus. So the MR just gets worse and worse and worse, and things just keep getting worse and worse and worse. Good. That's a good one. Very good.
What about, endocarditis.
Yes. Nah, you guys, you got see, it's coming together. Good. Endocarditis. We haven't even gone into endocarditis yet. So those are those vegetations on the valves. Yes, endocarditis can absolutely cause mitral regurg. So that's one of the things too. One of the telltale signs of someone who has endocarditis versus something else. So if we got dilated cardiomyopathy, what about any other of the cardiomyopathies could potentially cause MR?
Would hypertrophic cardiomyopathy be one?
Okay. Why? What condition? Like,
Is it the SAM?
yep. Very good. So SAM, so I'm gonna put SAM, so that's systolic anterior motion of that mitral valve leaflet. As a result, so I'm just kind of putting my little arrow there, as a result of ASH, asymmetric septal hypertrophy. So that asymmetric septal hypertrophy causes that LVOT obstruction or like, elevated velocities in the LVOT. So that that change in those velocities is enough pressure to actually suck up that anterior mitral valve leaflet when it's supposed to be closed. And that leads to mitral regurg. So yes, so SAM, so mitral regurg can be caused from that systolic anterior motion, that mitral valve leaflet, as a result of a patient who has a dynamic LVOT obstruction or as a result of asymmetric septal hypertrophy. And that is a hypertrophic cardiomyopathy. Good list. Good job, guys. Does anyone remember what the sound associated with mitral valve prolapse?
Is that the click?
Yep, the mid-systolic click. Yep. Where am I gonna put that in here? Mid-systolic. Kind of think about it, what that valve is doing, it closes, and then during mid-systole you hear that click. It kind of, that's that, prolapsing back. So it closed, then click, and then prolapses back. So mid-systolic click. Hope your notes are a lot neater than mine. I'm all over the darn place. Should be a football coach, but like, we're gonna go around this side and we're gonna. Go to this side. All right. Aortic valve. All right, aortic stenosis. Yes. So then the same thing, we got to do our aortic valve area. Here. So again, I always like to just kind of do my charts in reverse. Start with severe, because particularly with aortic and mitral valve, the numbers are easy. It's just one. So severe aortic valve area for severe mitral stenosis or aortic stenosis, you're gonna have valve area that's gonna be less than 1 centimeter squared. Moderate, it's gonna be the same as our mitral valve. It's gonna be 1 to 1.5 centimeters squared. And then this is going to be greater than 1.5 centimeters squared. So we can calculate or we can estimate degree of aortic stenosis, again, with a couple of different methods. The first one we can use is just, simply Dopplering our velocities through our aortic valve. So AOV velocity. So again, I just like to start with severe. So if you know you're severe, this is going to be aortic velocities that are greater than 4 meters per second. So if they give it to you in a different unit of measure, 4 centimeters per second equals 400. I'm sorry, 4 meters per second equals 400 centimeters per second. So don't be like, thrown off if they change the units of measure on you. Just be able to convert, meters per second into centimeters per second. 4 meters per second is the same as 400 centimeters per second. If we go then to moderate, this is going to be 3 to 4 meters per second for velocities through the aortic valve. And then mild is going to be 2.6 to 2.9. We could potentially have, if we're measuring velocities, a valve that is sclerotic and not necessarily stenotic. So just remember the difference between aortic sclerosis versus aortic stenosis. So with aortic sclerosis, we see, a thickening of the leaflets. There could be some calcification on the leaflets, but the leaflet motion or the orifice area hasn't been affected yet. So the motion of the leaflets isn't affected yet. So we still have good opening of the leaflets. So it's sclerotic, it's not stenotic yet. So we haven't really, affected our valve areas. But we can pick up sclerotic or can detect sclerosis because we do have some elevation, some mild elevation of velocities. So a valve that would be considered sclerotic would have velocities that are going to be less than 2.5, less than or equal to 2.5. But in terms of stenosis, these are going to be your values for velocity. So then the other things, the other measures that we can do are going to be either mean pressure gradient or our max pressure gradients. So again, more common is going to be your mean pressure gradient. It's a little more accurate than just measuring the max, particularly with patients that have arrhythmias. So our mean pressure gradients for aortic stenosis. So for here, mean pressure gradient for severe is going to be greater than 40. Nope, this is millimeters of mercury. Moderate, it's going to be 20 to 40. And then mild is going to be less than 20. You can also use max pressure gradient. For these values, this can be greater than 64. Use mercury, 36 to 64. And this is going to be 27 to 34.
Wait, I was a little bit confused about that because what happened to 35?
Yeah, good point.
I was looking over that in the book and it said the same thing. I wasn't sure if like one of the numbers was wrong or.
Well, let's go to my second source. Yeah, this is 36.
Oh, okay, thank you.
Putting it here. Have you guys gotten this book yet, or is it with this? This wasn't a required one, like the little pocket book, right?
I was gonna
No.
get it, but it was a little bit too expensive for me,
Also
so.
expensive. Pretty good, actually. I was going through it, and they like for each chapter kind of breaks it down.
Is
Alright,
that at the
so,
bookstore?
um,
Because I don't remember them offering it to me.
really? All right.
No.
I'll add it to the book list. All right, so aortic stenosis, so how do we calculate it? So the most common method, again, for calculating aortic stenosis is going to be our continuity equation. So aortic stenosis, you could still do planimetry. So we could be at our short axis at the aortic valve level, so our parasternal short axis. Zoom in nice and close on your aortic valve, and you trace when it's open during systole, and try and trace, along the opening of that aortic valve. So again, that could be kind of limited depending on your patient, but it also, it's fairly accurate as well if you can get a nice clear view. But more often than not, you're going to wind up doing continuity equation. So you guys remember the three criteria that you need for performing the continuity equation, the three things you're going to calculate.
The LVOT, VTI, and the area,
Yep.
and then the VTI of the past the aortic valve.
For us, we're going to measure diameter, LVOT. Which view did we do that in? You guys remember? Of course you do.
Parasternal long axis.
That's parasternal long axis. That's one of the measurements we do in our parasternal long axis. We measure diameter of the left ventricular outflow tract. The next thing we're going to do is going to be PW, pulse wave, of LVOT, either apical 5 or apical, I'm just going to apical 3 chamber. And then the last, and then that's going to be trace VTI. So we're going to pulse wave the LVOT and apical 5 or apical 3 chamber, and then trace the velocity time integral. So again, your trait. So if we have our tracing, we're going to trace along that curve, baseline to baseline. And the last piece of information we need to calculate our aortic valve area is going to be CW, continuous wave, through aortic valve, so AOV. We do continuous wave through the AOV, and then we trace VTI. It's going to be our tracing through the aortic valve, and we're going to trace along that curve. So again, that is also done in that same either apical 5 chamber or apical 3 chamber. So tracing these VTIs, once we calculate that and trace these VTIs, we're getting all the information to basically get all these values in our chart. So that's the beauty of our machines and calculating, all these values for you. So when you're writing up your report, just doing this, tracing your VTI, you're getting your mean pressure gradient because you're tracing the entire thing. And as you're tracing the entire thing, you're also getting your max velocity. So you're getting your max aortic valve velocity. So you can tell if it falls within these criteria. And since you're also getting that max velocity, you're also getting your max pressure gradient as well. So all those values and all those numbers come from you tracing that curve, tracing that Doppler, doing that Doppler spectral tracing along the envelope of it. All right, just gonna test you guys. So if I did my tracing, my Doppler tracing through the aortic valve, and I got something like that, that was late peaking, that had what's called the dagger shaped appearance. What does that potentially indicate? What would we associate that with? So instead of a nice parabolic shape, we get something that's late peaking. It makes this dagger shape appearance.
Is it hypertrophic cardiomyopathy?
Yeah. But more specifically, it's due to a dynamic LVOT obstruction or a dynamic subaortic obstruction. So that subaortic obstruction is due to that basal portion of septum becoming hypertrophied and thickened. So it's due to that asymmetric septal hypertrophy, which is the most common form of hypertrophic cardiomyopathy. So yes, so it is due to hypertrophic cardiomyopathy, which is acentric. It's acentric septal hypertrophy or asymmetrical septal hypertrophy that creates that obstruction in the left ventricular outflow tract. So since there's something blocking the LVOT, that left ventricular outflow tract, the peak velocities happen later in systole. So we get a delayed acceleration of those velocities. So that's why we wind up with this dagger appearance. So the velocity is starting to, they're slower to speed up. So that valve opens up. There's something blocking that blood flow from getting out. And it's relying more on the heart trying to squeeze it out. So those velocities, they're speeding up as the heart's contracting. And then your peak velocities happen later in systole. That's why you wind up with that dagger shaped appearance. It's due to something obstructing the outflow tract or an LVOT obstruction. So some sort of subaortic stenosis. Another term, idiopathic subaortic stenosis. So I don't know why they have to call all the same thing by all these fancy terms and acronyms, start confusing you. That's good. What's the most common cause of aortic stenosis? You guys should be shouting this at me.
Degenerative?
Degenerative, yes. So when we're talking about aortic valve, the most common cause is going to be degenerative changes. These are going to be calcified stenotic aortic valve leaflets. So it's going to be degenerative. That valve is, becoming diseased. We can also have rheumatic heart disease affecting it. So that's a cause. Not the most common when we're talking about aortic valve. It's still degenerative. Degenerative is the most common. So if it's degenerative aortic valve disease, we're going to see it in the elderly patients more often in the elderly patients, because again, it's something that's going to have to happen over time. So it's going to be by far more common in the elderly patients. If you're on your boards and it's a young patient that has aortic stenosis, what could potentially be the cause of it? Well, it's the most common congenital cause of aortic stenosis. Let's put it that way.
Is it coarctation?
Nope.
Bicuspid.
Bicuspid. Yep. There you go. Bicuspid aortic valve. Most common cause of AS. Degenerative. There's a G in there somewhere. So that's going to be calcified, thickened leaflets. So think elderly people. Elderly. Most common congenital cause. So bicuspid aortic valve. So on that, think young population. I know on your boards, they like to throw the patient's age in there, and sometimes that's a big clue for you to be able to answer the question. Sometimes it's just stupid, useless information. You know, they try and trip you up. I'll give you all this extra information about the patient that's not even relevant, you know, like a 40-year-old female with a limp walks in. No, I'm just kidding. Well, they do add like really a lot of information that you don't even need about the patient, you know, to kind of throw you off, but they're funny with some of the questions. So think of the young population. So if the question's about aortic stenosis and they're relatively young, go down the road of bicuspid aortic valve for your answer, because that's the most common congenital reason for aortic valve stenosis. The most common cause of aortic stenosis just in general is going to be our degenerative valve disease. So thickened, calcified leaflets that are, you know, immobile, they don't open very well. Rheumatic heart disease can also affect aortic valve, but not as common as our degenerative disease. So then if we're talking about effects on the heart, so now we just kind of, it's going to have a lot of the similar effects as our mitral stenosis, but now we're just involving the left ventricle now as well. So since this is a pressure, we're going to have left ventricular hypertrophy. That hypertrophy is going to be concentric, so it's going to be equal around all the walls. So that's kind of where we can kind of differentiate between someone who's got, you know, hypertrophic cardiomyopathy, because the majority of those are asymmetric, whereas a person who's got, you know, aortic stenosis that's causing that hypertrophy is going to appear more concentric. So the walls are going to thicken evenly. So in addition to that, after it's done hypertrophying, it's going to also then start to dilate. So we can also wind up with left ventricular dilatation or left ventricular enlargement after hypertrophy. Some other issues that can potentially happen. We can also start creating the situation where we're winding up with a situation where they could start developing left ventricular thrombus as well. So blood flow is having a hard time getting out, starts becoming more static. There's more stasis of the blood. So then we can wind up with the development of left ventricular thrombus. Thrombus is more often found in the apex of the heart. Kind of just think about, you know, anatomical where the heart's sitting is lying, the apex is down. So that's kind of where blood's going to want to, you know, eventually sit and pool. The development, well, we're going to get into that a little bit later when we start talking about our cardiac masses. So thrombus actually falls under under that as well, under that chapter, but I'll be honest with you guys, when we're talking about development of left ventricular thrombus, the presence of thrombus is not going to be very common if the patient has a good ejection fraction. If there's a good EF, if the heart's beating well, the chances and likelihood of you seeing a thrombus is fairly low. So even if that valve is very, very stenotic, if there's still good systolic function and there's good blood flow, like movement of blood flow, you know, it is stenotic, so I mean, it is limited, but like, if there's still preserved systolic function, the likelihood of finding thrombus is going to be fairly low compared to someone who's got a low EF. But there is that risk. So again, just think of this, everything now is then going to just back up. So after the left ventricle gets affected, it's going to then move on to the left atria, you know, and then eventually pulmonary vascular bed, lungs, back up to the right side of the heart, and then to the body. What are some things that we could see with aortic stenosis? So with our M modes, again, our M modes will have a thickened appearance to the leaflets with our diamond shapes. So our leaflets will appear thickened. They'll appear bright. So the cuffs appear thickened and dense and bright. If a patient has a bicuspid aortic valve, you know, there's something you could potentially see. This closure point will look eccentric. So this would be AS, like due to rheumatic or calcified disease. Calcified disease. There's bicuspid. So instead of meeting in the middle of that diamond, that bicuspid, the closure line between the two cusps is going to be abnormal. So it's going to be displaced. So you'll see that closure line closer towards the right coronary cusp. So we'll do aortic regurge next. So aortic regurge isn't too bad. There's really only one series of numbers that you have to remember in terms of for aortic regurge. So we use pressure halftime when we're assessing aortic regurgitation. Aortic insufficiency. So it's really all about your aortic regurge tracing and what it looks like that you can know right away if you're dealing with mild aortic regurgitation versus something that's severe. So mild, severe. So don't get confused between severe mitral stenosis and aortic regurge or aortic insufficiency, because they're going to be opposite of each other. So mild AI is going to have a very flat slope. It's going to be a very light tracing. The fainter it is, the lighter it is, the less severe it is. Conversely, if you have a very steep slope that you're measuring your pressure halftime along, and a very bright, intense spectral tracing, that indicates something more severe. So just looking right away at the two tracings, you should be able to tell, what is mild versus something that's more severe. And then you're going to measure your pressure halftime slope again. Trace along the slope of that line. Slope of your line. So we're going to measure pressure halftime. So a little chart for pressure halftime. Mild. Well, that's going to be pressure halftime. just put mild. That's gonna be greater than 500 milliseconds. So if you kind of think of this as a linear measure of time, like how much time it took for this pressure to drop by half. So if that's my drop, you know, well, I mean, the machine's actually going to calculate that all the way out, but you're just getting the slope of that line. So the time it takes for it to drop by half is much longer than, say, it took, you know, to drop by half here. So this time to that time is much shorter than, you know, that time to that time. So this is going to have a much longer pressure half time. So just remember, greater than 500 is mild. 200 to 500 is moderate. And severe, it's going to be less than 200. So those are your numbers for aortic insufficiency. Basically, this is measuring how fast it takes for the pressures to equalize, you know, between those two chambers. So if you think about it this way, you have a very large opening or regurgitant orifice area, a very large hole that blood flow is leaking back through. The pressures are going to equalize very fast. So that's why you're going to wind up with a very steep slope. So just remember the characteristics for your different jets. Regurgitant jets, mild versus severe. When does aortic regurgitation occur? During systole or diastole?
Diastole?
Diastole, yes. Got to be quick on the draw. All right. Da. All right, tricuspid. So tricuspid stenosis for the tricuspid valve. So most common causes for tricuspid stenosis, the most common is going to be rheumatic heart disease. Second most common is going to be carcinoid. Heart disease. We can also have congenital. So it could be due to some sort of congenital abnormality. So an example of congenital abnormality that could cause tricuspid stenosis would be our Epstein's. Anomaly. So Epstein's anomaly is that displacement of the tricuspid annulus or the leaflets towards the apex of the heart. So we get a smaller right ventricle, a larger right atria. So we can really appreciate that in our apical 4-chamber view. So in that case, you'll notice that you'll get your tricuspid valve displaced towards that apex. So they often call that or refer to that as atrialization of the right ventricle. So atrialization, so the right atria becomes much larger compared to the ventricle. So they say atrialization of the right ventricle is associated with a condition known as Epstein's anomaly. It's displacement of those tricuspid valve leaflets towards the apex of the right ventricle. Just remember, carcinoid heart disease is again more common on right side of heart. Tricuspid regurge causes. So the most common causes, it's going to be degeneration of the tricuspid valve due to myxomatous disease. That's the most common cause of primary tricuspid regurge. Just remember, most people, it's common to have a little bit. Same thing with mitral regurge. We can have tricuspid regurge due to displacement of the mitral and tricuspid annulus. So if we get dilatation of that right ventricle, that's going to displace the annulus, pull the annulus apart, so those leaflets won't be able to coapt properly. So any situations where we have right ventricular enlargement, that can cause tricuspid regurge. So this would be a secondary cause of tricuspid regurge. So that dilatation of the right ventricle, you know, could be due to issues on the left side of the heart. So just keep that in the back of your mind. We can also see tricuspid regurge as a result of rheumatic heart disease as well. We could also see it as a result of, you know, endocarditis, vegetations. So if we see vegetations on the right side of the heart, we can raise the suspicion, you know, potential intravenous drug abuse being a cause of that. So with tricuspid regurge, we could use our tricuspid regurge maximum jet velocities to try and calculate pulmonary hypertension. So we can estimate our pulmonary artery systolic pressures. By tracing or calculating our tricuspid regurgitant jet peak velocities. So TR is used to calculate pulmonary artery systolic pressures, which is the same. So they equal the right ventricular systolic pressures. So right ventricular systolic pressure and pulmonary artery pressure are the same. So the equation that we use to calculate our pulmonary artery pressures. So PA systolic pressure equals 4 times TR max squared plus our right atrial pressure. That right atrial pressure we estimate by assessing the inferior vena cava for dilatation and collapse. Calculator. So I'm kind of using Juliana as our example. Do you remember what we measured? I think it was the max velocity. I think what did we get, like 24 centimeters per second? So if we put that into our equation, so this is meters per second. So we have to convert that 24 to meters per second. Four. Oh, you're welcome. Yeah, I'm over here just in a lecture.
Thank you so much.
Have fun.
Dan.
Yeah, you're welcome. It was from all of us. It's
appreciate
from all of
it.
us. No, we
Okay.
appreciate everything you do, seriously. Right?
Thank you so much. Well, you guys make me feel appreciated, so you'll keep getting good work.
Good, thank you.
All right.
All right.
Bye, Jen.
Give me a hard time doing the decimal here. Squaring the decimal isn't really working out for me. Small number. Anyway. Four. So if we get it, just using some fake numbers. So if we get 2.4 times 2, that's 4.8 times 4, 19.2, and then we estimate right atrial pressure of 5. That would give us 24, which would still fall under category of normal. So there is a little chart for determining, your pulmonary artery systolic pressures. So just remember, greater than 70 would be considered severe pulmonary hypertension. So for pulmonary hypertension, so this is our systolic pulmonary artery pressures. So severe, we have a pressure that's going to be greater than 70 millimeters of mercury. Moderate, it's going to be 40 to 70. 30 to 40. There's a little bit of a gray area there between 25 and 30. Typically over 25 is up to 25 is considered normal. So 25 at rest, greater than 25 at rest, or greater than 30 with exercise. So with tricuspid valve, again, one of the most common congenital anomalies that we could potentially see is going to be our Epstein's anomaly, atrialization of that right ventricle. Carcinoid disease, more common on the right side of the heart. Most common cause of tricuspid stenosis is still rheumatic heart disease. Rheumatic. Most common congenital heart disease causing tricuspid stenosis would be Epstein's anomaly. Epstein's anomaly, there will also be some degree of tricuspid regurge as well, just because those leaflets aren't placed properly. So it may be displacement of a single leaflet or both leaflets, so it may not be the entire tricuspid annulus that's displaced up towards the apex. So we may have displacement of a single leaflet or two leaflets. So that would for sure cause some degree of tricuspid regurge. When we're talking now about pulmonic valve disease is rare. If there is pulmonic disease that we encounter, the most likely cause is going to be some sort of congenital malformation. So if it's some sort of congenital malformation, this is typically going to be discovered, when these patients are newborn, when they're babies, very young. So the chances of you, discovering something that an issue with the pulmonic valve when you get the patients later in life, if you're staying on this, as an adult or as an elderly patient, and you being the first person to discover this is going to be highly unlikely. So with pulmonic valve, and so it's going to be likely due to congenital disease. It's going to be very rare. Very rare. So. Sorry, they're texting me about comps. Pulmonic disease is going to be very rare. It's uncommon. If we do encounter it, it's likely due to congenital disease. When we're talking about pulmonic stenosis, PS, we have to classify it as either subvalvular, valvular, supravalvular. So is that stenotic lesion, or is that issue with the pulmonic valve? Is it just below the valve in the right ventricular outflow tract? Is it at the valvular level? Does it have to do with some sort of congenital malformation of the valve itself? Is this the valve atrophic? Is it, are the commissures fused? Is it some sort of issue with the valve itself? Or is it a supravalvular stenosis? So are we talking something going on in that pulmonary artery? So those are the three criteria that we look at when we're talking about pulmonic stenosis. So we want to classify, the location of that stenotic lesion. So when we're talking about pulmonic stenosis, again, it's usually congenital. So we can have, bileaflet or a unicuspid or a bicuspid or dysplastic pulmonic valve. It could be, again, associated with congenital abnormalities. So when we're talking about pulmonic valve, the big congenital anomaly that, is associated with pulmonic stenosis is going to be our tetralogy of below. Some other causes, potentially of pulmonic stenosis, could maybe be some sort of mass or tumor, within the right ventricle that could be obstructing outflow. Carcinoid heart disease would be the most common form of acquired pulmonic stenosis. Carcinoid. Tumor blocking LVOT. Where am I going to next? Let's see. All right, let's do really fast, super fast cardiomyopathies. Cardiomyopathy. Who wants to give me a definition of cardiomyopathy? What is it? What do we talk about with cardiomyopathies? It's a disease of what?
Myocardium.
Myocardium, yes. So it's a disease of the myocardium that's not associated with anything else, causing it. So it's not associated with something like hypertension. It's not associated, with valvular disease. So this is a disease of the myocardium itself. That's not caused by something else. What are our three cardiomyopathies, the three main ones that we go over? Dilated, hypertrophic, and then restrictive cardiomyopathy. So restrictive is also referred to sometimes as infiltrative cardiomyopathy. So what does dilated cardiomyopathy look like? When someone says I have dilated cardiomyopathy, or we're suspecting dilated cardiomyopathy, we put the probe down. What is that heart going to look like?
Left ventricle will be dilated.
Both ventricles? Yeah. Okay. And what else? I would say both
Kinda
atria
like-
too. I say
Kind of like a circle.
Yep. So I would say that when I think dilated cardiomyopathy, I think all four chambers dilated. This whole heart is huge. It's a big leaky heart. So dilated cardiomyopathy, I see first off dilatation of the left ventricle. So the classic definition for dilated cardiomyopathy would be left ventricular enlargement. So left ventricular dilatation, we need a big dilated left ventricle. And what's that second component, that second criteria? So we need two things to really say that, yes, this person has dilated cardiomyopathy. There's two primary characteristics that have to be satisfied.
Systolic dysfunction.
Systolic dysfunction, good. So DCO, dilated cardiomyopathy, we need left ventricular enlargement and systolic dysfunction. That's reduced. Yeah. This patient has to have a bad ejection fraction. So we need a big dilated left ventricle and a reduced EF. So those are your primary characteristics of dilated cardiomyopathy. So that's what defines dilated cardiomyopathy. Then all the other things that we could see along with it are secondary findings that are associated with dilated cardiomyopathy. So again, so as that left ventricle dilates, those mitral annular spreads. So we often see mitral regurge. Got MR. That MR is now causing worsening left atrial enlargement. So you got dilated atria. All that extra volume now goes back to the right side of the heart. Right side becomes dilated. So right ventricular enlargement. Right atrial enlargement. That's why with dilated cardiomyopathy, I think of four big dilated leaking chambers. Big leaky heart. All chambers now become dilated and enlarged. And then because we also have reduced systolic function, these patients, they often run the risk now for developing thrombi. You know, you could see thrombus in the ventricles, you could see thrombus in the atria. So this is just a condition that's going to get worse and worse and worse and worse. So these patients, they ultimately are going to need a heart transplant. But what are some treatments that we could potentially do for these patients to try and help them in the interim while they're waiting for a heart transplant? Anyone remember some of those?
The biventricular
Good.
pacemaker.
Yeah, biventricular pacemaker. Yep. Biventricular pacing. That helps to, you know, improve some of that contractility on the ventricles, helps improve the patient's EF a little bit, try and get some of that blood out, try and reduce some of those chamber dimensions. Biventricular pacing. But ultimately, will need heart transplant. So because this patient has a reduced ejection fraction, our aortic valve M mode, we could potentially see early closure of that aortic valve M mode. So our aortic valve M mode might look something like that. That's due to reduced. Yeah. So we got poor contractility that causes that early closure of aortic valve. Uh, So just think about it with dilated cardiomyopathy. You just have to think about all the things that could potentially happen when we start having, regurgitation through that mitral valve and patients with reduced ejection fractions. So same thing holds true, pulmonary congestion, pulmonary hypertension. As you get, enlargement of the right ventricle, you wind up with worsening tricuspid regurgitation, which leads to more dilatation of the right atria, and then all that just translates dilated IVC, dilated hepatic veins, eventually spreads to the rest of the body. Those patients wind up with extremity swelling, edema. They're very short of breath. So hypertrophic now cardiomyopathy. Hypertrophic cardiomyopathy. HCO. We'll just say HCM cardiomyopathy, whatever. So with hypertrophic cardiomyopathy, most common is going to be our asymmetric septal hypertrophy. So asymmetric septal hypertrophy, that's going to be your most common. So that's typically seen along the basal portion of the septum, near the level of the left ventricular outflow tract. So since this is the most common location, asymmetric septal hypertrophy will cause conditions like idiopathic sub-aortic stenosis, idiopathic sub-aortic stenosis. Causes dynamic LVOT, left ventricular outflow tract obstruction. Causes potentially SAM. So systolic anterior motion of that mitral valve leaflet. Systolic Motion. Mitral valve leaflet. So it's that anterior mitral valve leaflet. So SAM causes MR or mitral regurge. So our dynamic LVOT obstructions, there's two things that we can do to bring them out or to, intensify or magnify, or if, we're ever questioning, like, I really am not detecting an LVOT obstruction, but I want to be doubly sure. We can have the patient Valsalva, or we can administer amyl nitrate. To, let's say, augment, so we can make larger or bring out, augment LVOT obstruction. We also when we're talking about hypertrophic cardiomyopathy, we want wall thickness greater than 1.3 centimeters. We also can have concentric LVH. So left ventricular hypertrophy that's even along all walls. We can also have apical hypertrophy. So apical hypertrophy. That is more common in Asian population. So with hypertrophic cardiomyopathy, these patients have normal to hyperdynamic LV systolic function. So sometimes with these patients, the muscles have become so thick that the cavities become so small that pretty much all of the blood, that enters is getting ejected. So they can have a hyperdynamic systolic function. With hypertrophic cardiomyopathy, ventricles eventually become less compliant. So those muscles become big and thick and strong they're not able to stretch and relax. So think of it, as the big bodybuilder, walking in, he's got those big, huge muscles, but the guy can never touch his toes. He's like, really stiff. So that ventricle now has become stiff like that. It's not able to relax and stretch out, So these patients, since they have reduced compliance, they start winding up with diastolic dysfunction. So hypertrophic cardiomyopathy leads to diastolic dysfunction. To reduced LV compliance. Guys, does anyone remember what some treatments are for the hypertrophic cardiomyopathy?
The alcohol ablation.
Yep. It's one of them. Alcohol, and your problem. Alcohol ablation. So I go in with a little needle into the thickened areas. Insert this ethylene alcohol that actually destroys the tissue and thins it out. So that's alcohol ablation. They can also do a myectomy. They can actually go in there and basically they're shaving down the myometrium, myocardial layer, myometrium. God, I'm getting into the uterus. Jesus Christ. They can shave down the myocardial layer and reduce that thickness. So they're actually basically shaving down the muscular layer to try and relieve or try and open up. The main thing is to try and open up that LVOT to create less stress on that heart, to allow for easier passage of blood flow out of the ventricle.
Don't they always also give like the drugs to make the heart beat a little slower or something?
Yep.
Or is that something else?
No, you're right. Like beta blockers. Where are we? Let me get into my drugs here. Hook 'em. Myectomy, not myectomy, sorry, myectomy. Let's see. Get my list of drugs. For the midterm, remember beta blockers and how that works on the heart. DTCC. Does anyone want to tell me what a heart looks like that has restrictive cardiomyopathy? While I'm looking this up, the meds.
Enlarged atriums.
Yep, so biatrial enlargement. What's the appearance for the ventricles if it's amyloidosis? What do we say? Anyone remember?
Are they hypertrophic?
There is some thickening to it, but the main thing that we see, the main appearance of it is going to be called a speckled ground glass appearance. So that's due to those amyloid infiltrates getting into the myocardium. So it's going to have a what's called a speckled ground glass appearance, and there is going to be some thickening to it as well, but not to the degree of a hypertrophic cardiomyopathy. Can anyone tell me about the systolic and diastolic function in a patient with restrictive cardiomyopathy? Teach each other.
Isn't it something like the ventricles are working fine? Something like that.
So they have normal systolic function. So they have good preserved systolic function. But the issue now is that the myocardium has become stiffened due to those infiltrates. So those amyloid, particularly amyloidosis. So amyloidosis is going to be your main culprit, your main cause of restrictive cardiomyopathy. So amyloidosis, restrictive cardiomyopathy, put those two terms together. So yes, so the ventricles, they're able to contract fine, but now the myocardium has become stiffened and it's not able to relax. So we have now diastolic dysfunction as the main issue with patients with restrictive cardiomyopathy. Trying to just look at some of these drugs. Yeah, I'm just kind of looking through a test. So yeah, just essentially beta blockers is the only one I was really asking about in terms of like the meds. I know like one of our slides for hypertension, congestive heart failure, Like there was a list of like different medications, like ACE inhibitors and, calcium channel blockers and renin inhibitors and all that. The only one I really want you to know is beta blockers, because that's one of the more common ones. I mean, things that work on the kidneys, like diuretics. If you just think about it, what a diuretic does, it helps to remove fluid or water from the blood. You're peeing out the excess water. Well, essentially, it eliminates sodium. So where sodium goes, water follows. So it causes you to pee a lot, the diuretics, to remove excess fluid from the body. So removing that excess fluid helps to reduce blood volumes, and reducing that blood volumes, helps to control hypertension or blood pressure. So a lot of these work are mainly for controlling blood pressure. So these drugs treatments that were listed, those are different treatments for controlling hypertension. All right, so with restrictive, going back to restrictive cardiomyopathy. So we know it's a disease that causes diastolic dysfunction primarily. So that's going to be the main thing that we're worried about now with restrictive cardiomyopathy. Reason it's diastolic disease is because those atria are becoming dilated. We're having ever increasing atrial pressures. And that leads to worsening and worsening of that diastolic dysfunction. So that the ventricles, they're becoming stiffer, non-compliant. We're having increasing pressures in those atria. So it is the disease of, it's a diastolic dysfunction disease. So just be aware or familiar with our diastolic dysfunction chart, that I had you draw out, knowing your different degrees of diastolic dysfunction. So know your first stage of diastolic dysfunction is going to be our impaired relaxation. Second stage of diastolic dysfunction is going to be pseudonormalization. And then our third and fourth stages are going to be our restrictive filling patterns. Three and four for our restrictive filling patterns. There's reversible, and then fixed or irreversible filling pattern, or reversible restrictive filling pattern, or a fixed or irreversible filling pattern for stage 4. You can use Valsalva maneuver to differentiate between either pseudonormal versus a normal filling pattern when we're talking about our mitral inflow. Just remember, you have the patient Valsalva, and then your E and A wave will revert to an impaired relaxation. So that's how you can tell the patient is actually at pseudonormal. And same thing, you can have Valsalva when you're looking at the not the mitral inflow, the pulmonary venous flow now. So our pulmonary venous, or our pulmonary vein flow, you can tell the difference between restrictive and fixed or fixed restrictive or reversible. So where's our charts? Just remember your deceleration times too for our E and A for our mitral inflow. Your E to A ratio for your different levels of dysfunction. Your E to E prime ratios. So remember, you can also use tissue Doppler. You can use your pulmonary venous flow, your pulmonary vein flow to assess for diastolic dysfunction, as well as or mitral inflow. So I just want to go over some of these questions. So left ventricular remodeling. This occurs as a result of necrotic myocardium being replaced by fibrosis and scarring. So with this, this happens post MI. So after patients had a heart attack, and that patient has ischemic damage to the tissue, that heart is going to try and remodel, or the left ventricle is going to remodel itself to function with that area that's necrotic. So the shape of that left ventricle is going to change. So you're going to potentially wind up with areas that become, dilated or potentially even aneurysmal. And that's due to a patient who's had a myocardial infarct, that the tissue has died and now been replaced by a fibrous scar tissue. So that's another good point too. So a patient who's had a heart attack and that myocardium dies and becomes fibrotic, it's thinner, yes, but it's also fibrotic. So it's tough, it's stiff, so it's thin, it's echogenic, so it becomes brighter because it's fibrotic, but it's also very tough. It's very rigid. So that scarring, that scar tissue that results after the patient's had a heart attack, is not very likely to rupture. So these patients aren't likely to develop an aneurysm in that area. Even though it's thin, it's fibrotic. So it's tough. It's, I want to say, it's fibrous tissue. So it's very hard to break. So which coronary artery feeds the inferior wall of the left ventricle? That's going to be your right coronary artery. Which wall segments of the left ventricle are visualized in the apical two-chamber view? So that's your anterior and your inferior walls. Angina is an early indicator of ischemia according to ischemic cascade. So this is false. So chest pain is actually one of the last things that's going to happen in a patient who has coronary artery disease. If you're looking at that ischemic cascade, so one of the first things that we're going to see is potentially diastolic dysfunction, or even changes in our EKG. Before we see any sort of left ventricular, wall motion abnormalities, before the patient has any sort of chest pain. There are other things that come well before that. So go back in your slide, look at that ischemic cascade, and see where, angina and chest pain and some of these telltale signs of a patient having a heart attack occur on that ischemic cascade. So complications of left ventricular myocardial infarct may include all of the following except. So a patient has an LV infarct. Are we gonna have mitral regurge? Yep. If they have a left ventricular infarct, that means they probably have a reduced EF. So they run the risk of thrombus formation, yes. Papillary muscle rupture, yeah, potentially there could be papillary muscle rupture, depending on which coronary artery is affected. So the only one that really isn't an issue would be aortic regurgitation. So that aortic valve and the annulus, that's not something that would be affected by poor coronary artery flow. Which coronary artery supplies the basal portion of the intraventricular septum in the four-chamber view? So that's going to be the right coronary artery. Normal E-point septal separation of the left ventricle. So it's going to be the smallest number. 2 centimeters is huge. 1 centimeter is pretty big. 1.2 centimeters is big as well. So it's 6 millimeters or less. It's usually between 2 and 6 millimeters is that E-point septal separation. All right, 17. So chronic hypoperfusion, so chronic poor perfusion of the myocardium is called myocardial hibernation. So this is a systolic dysfunction where the myocardium, isn't contracting properly. That's a result of this chronic hypoperfusion. So in these patients, if we stent open those arteries, normal cardiac function will return because that myocardium was just hibernating. It was kind of just sleeping because of this chronic hypoperfusion. I guess that's kind of worded poorly. It's more chronic hypoperfusion of the myocardium is due to, or I want to say, chronic hypoperfusion of the myocardium is a cause of myocardial hibernation. So just know the difference between, I'm just going back to this one, between myocardial hibernation and myocardial stunning. So stunning is due to an acute process. So that's an acute ischemic event. So the myocardium wasn't getting blood flow all of a sudden. And if it was only for a short period of time that the myocardium was without blood flow, the myocardium, the heart muscle is just stunned. So we should have returned back to a normal myocardial function. So if that ischemic period was less than 5 to 6 hours, I like to use 5 hours as my golden number. So if it's less than, I believe it's 4 to 6, they say. So if it's less than 4 to 6 hours, function of that myocardium should return. It could take, 24 hours, could take up to 72 hours, could take several days, could return fairly quickly depending on the duration or period of which, that myocardium was not receiving blood flow. So myocardial stunning is different from myocardial necrosis. So myocardial necrosis is when that myocardium was without oxygen or without blood flow for an extended period of time. So over that 4 to 6 hour period, then you're going to wind up with tissue death, and that's the necrosis. So that tissue death can eventually wind up with myocardial necrosis. So that's that thinning and fiber scarring of that tissue that we see in patients who've had a heart attack. already. You guys, what am I even sharing? Am I sharing the right thing? Are you guys seeing these questions? Or no?
No,
Let's talk up, please. I'm just kind of on autopilot here. I'm going like stop shares there. I forgot I have to do this whole jazz again. Where I got to share this and then stop share and then go back. You guys
I
are-
wasn't sure if you wanted us to see it or not.
Yeah, you've already taken this. Of course.
Yeah, I thought you were just reading them to us. I didn't realize you wanted us to see it.
Yes, I want you to see it because you got, I'm all about learning multiple ways. Hearing my voice ain't gonna stick in your head. I need to see things. Guys, see my pretty face. All right, so acute hypoperfusion of the myocardium where the ventricular, so acute hypoperfusion. So when we're getting acute low blood flow to the myocardium where ventricular function returns after 36 hours is called, so this is your myocardial stunning. So when we get a sudden acute episode of hypoperfusion to the myocardium where we're getting poor perfusion to that muscle tissue and the ventricular function returns after 36 hours, this is the myocardial stunning. So this is an acute event. Myocardial stunning is with an acute event. Myocardial hibernation is with a chronic over a long period of time. So a long duration event, something the patient's had for a long time. So this one. Aneurysm rupture. So aneurysm rupture is more likely to occur in, so this is areas of acute myocardial expansion. So we have something that can occur if a patient's had a heart attack and the left ventricle all of a sudden remodels very, very quickly and dilates. We get an area where it starts to dilate very quickly. That area that dilates very quickly is referred to as acute myocardial expansion. Since it dilates very quickly, it doesn't get a chance to form that fibrous scarring. So that scarring is what helps prevent aneurysmal rupture because it's fibrous. It's fibrous scarring, fibrous dense scarring. So if it expands really fast, this acute myocardial expansion, those patients run a high risk of having aneurysmal rupture of that wall segment. So areas that are more susceptible and more likely to develop or have aneurysmal rupture are areas that undergo acute myocardial expansion. So acute, a very fast expansion of that myocardial tissue prevents the development of that scar tissue in that damaged area. So that is the best answer out of those. So the scarring is good. The scarring will actually protect the ventricular walls or the myocardial walls from rupture because that scarring, again, is fibrous tissue. So it's thick. It's not thick. It's dense. I don't want to say thick. It's thin because it's thinned out, but it's echogenic and it's dense. Development of a pericardial effusion post-MI. So this is referred to as Dressler's syndrome. So based on the image below, what left ventricular filling pattern should be considered? So we look at this mitral inflow. We look at it, we have a lower E wave and a higher A wave. So it's giving us a very long deceleration time. So this is greater than that 240. We have an E to A ratio of 0.65. So this is an example of impaired relaxation. So this is a first level or first degree diastolic dysfunction this patient has. This is an example of impaired relaxation. What is the effect of Valsalva maneuver on mitral inflow on a patient with normal diastolic function? So on a patient that has normal diastolic function, so they're not in any of those stages of diastolic dysfunction, Valsalva will actually decrease both the E and A waves equally. So in a patient that has diastolic dysfunction, when we have them Valsalva, we'll get a decrease of the E wave and an increase on the A wave. So that's how we can unmask patients that have diastolic dysfunction, because there's an unequal due to us changing the inflow volumes. We can unmask those elevated filling pressures by having the patient Valsalva. So just know that it reduces both velocities equally. So we get smaller E and A waves, but the ratio doesn't change. So on patients that have normal diastolic function. That one was a little bit tricky. So a sonographer should suspect stage 4 diastolic dysfunction when. So the answer is going to be if we have an E to A ratio that's greater than 2, and then a very fast deceleration time, so less than 140. It's going to be this last one. So we have a very big E, little a, and then a very sharp, fast deceleration time. We're measuring along that slope of that E wave. So the following mitral Doppler waveforms were obtained from a patient and then repeated during Valsalva. What should the sonographer, should say sonographer, sorry, my bad, sonographer consider? So if you look at this, we're Dopplering mitral inflow, we have E to A. So this looks pretty normal. We should expect a larger E and smaller A. Patient Valsalvas, oh, now we got reversal of that E to A wave. Sorry. So this would be a patient who is in stage 2 diastolic dysfunction. So that's that pseudo normalization. Uh, let's see what else. Ta-da. Mhm. There's one term I want to make you guys familiar with. I don't know if we discussed it yet. Have we ever mentioned Eisenmenger syndrome? We're gonna go into this Eisenmenger's. I got my son text messaging me. I think he's mad at me. So Eisenmenger syndrome. So this is a condition where we get it refers to intracardiac shunts. So we're going to talk about this when we get into congenital heart disease. So if a patient has a ventricular septal defect, this is going to be our LV, RV. Pressures are higher on the left side. So if there's a shunt, an intracardiac shunt, so a hole like a ventricular septal defect, pressure is going to take blood flow from the left ventricle into the right ventricle. So that's where blood flow is going to want to go. It's going to want to go from left into right. So that's going to be your normal flow direction for any sort of intracardiac shunt. So if they have an atrial septal defect, pressures are going to be higher on the left side of the heart. So blood flow is going to go from the left atria into the right atria. So intracardiac shunts, when they first form, are going to typically be left to right shunts, from higher pressure to lower pressure, from left side of the heart to the right side of the heart. So with Eisenmenger syndrome, we get a reversal of that shunt direction. So intracardiac shunts become either bidirectional or they reverse completely and become right to left shunts. So Eisenmenger syndrome refers to the condition where intracardiac shunts reverse and right to left shunts. Normally they're left to right with Eisenmenger syndrome. Because the blood flow for a while has been going from left to right, pressures on this side now start to elevate and start to equalize and may actually become higher, so that shunt starts to reverse. So you can wind up with bidirectional and then even reversal of flow. So shunt direction reverses. That's Eisenmenger syndrome. So it's when shunts reverse and become right to left. I'm just kind of going through some of like, the choices on like some of these questions, and I don't think I ever mentioned Eisenmenger syndrome. So Eisenmenger syndrome, that's when intracardiac shunts reverse and become right to left. So typically shunts are left to right from high to low. The shunts, they're ongoing for a certain period of time. So pressure start rising on the right side of the heart, and then those shunt directions will actually reverse and become right to left. So that's Eisenmenger syndrome. Da. Again, just remember preload, afterload. We went over the cardiomyopathies. We went over the valves. Be familiar with endocardial fibroelastosis. Be familiar with your coronary artery perfusion wall segments. Risk factors for hypertension, etiology of hypertension, the most common etiology for systemic hypertension, we know idiopathic. Some treatments for your cardiomyopathies we went over. Know your myocardial stunning, like myocardial hibernation, myocardial expansion, what it looks like when there's, the description of like, what myocardial necrosis looks like when you develop that scarring. What does the tissue look like? Know your diastolic dysfunction, how to diagnose, your values for that. Again, your valvular disease, your numbers, your values. Being able to look at some of those Doppler waveforms to determine, so I'm going to give you some pictures, for mitral valve, measuring pressure halftime, or a VTI for a mitral valve. Same thing with the aortic valve. For aortic stenosis, aortic regurge, mitral stenosis, mitral regurge. Trying to think what other things. When we're talking about systolic dysfunction, so patients that have bad EF, some of the things that we can see, we could see, that decreased E-point septal, or I'm sorry, increased E-point septal separation. We see reduced motion of the aortic root. So remember, with a person that has normal systolic function, when we do end mode of that aortic root, we see it swinging, like, through our cardiac cycle. So patients that have a bad EF, the aortic root stays relatively flat. I think. Is there anything else that you guys had any real questions on before I let you go? Oh, another one, hypereosinophilia syndrome. So the two ones that to be familiar with, hypereosinophilia and the endocardial fibroelastosis. So just kind of look at those two slides. My son's pissed because I was working on his his laptop at home, like doing stuff that I needed to do. He says I ruined his work. He's convinced he works for YouTube. I should see the messages he's sending me. All right, any questions for you guys to enjoy your couple days off?
I did for the prosthetic valves. Where it says like the prosthetic valve clicks, is that just for like mechanical or is that for the bioprosthetic too? Like when you do Doppler and like it clicks in the Doppler?
That is with just the mechanical valves. So
Okay,
bioprosthetic valves, well, that's one way to tell if it's either a mechanical or a bioprosthetic. So the bioprosthetic, the porcine or the bovine, or if it comes from a human graft, a human donor, it's not going to have those sharp clicks. So that's one way to tell, yes, if it's mechanical versus bioprosthetic.
okay. And
Oh, for prosthetic valves, yeah, so just be familiar with like the different kinds. For mechanical, Star Edwards is your ball and cage. York Shiley is your single tilting disc. And then was it St. Jude is going to be your bi-leaflet. And Carpentine Edwards is going to be your, right, isn't that the bioprosthetic? No, I guess also for, in terms of mechanical versus bioprosthetic, like the advantages of each. So like with mechanical valves, you know, they have more longevity, so they're more durable. They're intended for patients that are younger, but they do require disadvantages. They require the patient to be on anticoagulation. And they're also inherently more stenotic, as well as have more regurgitation to them. Bioprosthetic valves, they're less durable, so they don't last as long, but they're less stenotic. They have less regurgitation. And sometimes they don't require patients, you know, to even be on any sort of anticoagulation therapy. So those patients may not have to go on, you know, anticoagulation therapy, whereas someone with a mechanical valve absolutely does. Know the term dehiscence. That's important. So that's the actual separation, you know, of that valve apparatus from, you know, the annulus wall where it's sewn in. So evidence of dehiscence, you'll see paravalvular regurgitation or paravalvular leaks. So regurgitation around the outside of that valve structure, around the periphery of it. One also disadvantage of a bioprosthetic valve. So for those either bovine or porcine, the same disease processes that damaged your native valve are also going to damage those bioprosthetic valves as well, because it is still living tissue. Also know that mechanical valves, there's also limitations due to limitations in imaging due to shadowing artifact. So there's a lot of artifact that's involved with the mechanical valves.
I have one more question,
Sure.
for the prosthetic valves. So unless I like was going over it wrong, it sounds like normally there will always be like some degree of stenosis and regurge.
Typically, yeah, absolutely with mechanical valves. It's not as much with the bioprosthetics, so it just might be minimal regurge and stenosis. Because those valves are also going to be smaller than our native ones, particularly if they're taken it porcine. But they're going to make it smaller because they have to sew it. There's a ring that it's attached to, so that ring gets attached then to the annulus, so that the valve areas they're gonna be smaller than what typically our native valves are going to be. So they are going to be inherently a little bit stenotic. But then again, it's all, it depends on the manufacturer and what what they determine to be significant stenosis. So you have to know, the manufacturer, what type of valve it is, the size it is, to be able to calculate, is this a normal degree of narrowing or stenosis, or is this something that's, a process that's going on? Like, is it something that's critical?
Well, thank you so much. I gotta go because I gotta pick up Max, but thank
Yeah.
you.
That's okay. We're good. If
Dan, I did talk to Nicole today from Riddle, and she said I'm fine to come in on Monday as long as
Yeah.
you're.
appreciate
All right,
it.
cool. All right, thank you. Have a good weekend.
Yes,
Bye.
Good luck with your son.
I'll see you.